Good afternoon, everyone. I see that people are slowly trickling in. We'll get started since it's 12. Thank you for joining us for the Chagas Echo series brought to you by San Diego State University, UT Health San Antonio Echo, Texas State University, and the South Coastal Area Health Education Center. Um, I'm Cato, and I have a couple housekeeping announcements before I pass things over to Dr. Stigler Granados. Please stay muted unless you are speaking, and we do encourage you to speak. You can use the chat to ask questions, answer questions, and share any perspectives you may have. And please note that no protected health information is allowed in either the chat or our discussions. Also, if you want to review any of this content later, please know that we are recording these sessions for later distribution through our Chagas Echo website. And towards the end of the session, we will send out a link to a quick evaluation survey. Next slide, Angela. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and filling out this survey also qualifies you for receiving free CME credits. Slide, Angela. For those who may be new to ECHO, it stands for Extension for Community Healthcare Outcomes. This is a model of lifelong learning and guided practice that connects community-based health workers with each other and team of subject matter experts to create a community of practice and learning. Our aim in this series is to build knowledge, skills, and understanding among the health workforce about Chagas disease. We support each other's growth through these regular sessions that include didactics, cases shared from the community of learners, and groups to share resources, challenges, and strategies for Chagas screening and care. With that, I will pass this over to Dr. Stigler Granados. And next slide, Angela.
Paula, you're muted.
I am so sorry. My screen jumped away and I couldn't find myself anymore. So I apologize. I'm not a Teams expert. It went away and I couldn't find it. Thank you all so much for being here. I am Paula Stigler-Granados. I am associated with San Diego State University, associate professor, as well as with Texas State University. I'm an adjunct professor there, working on Chagas disease. This also, ECHO sessions, I wanted to say, are funded through our cooperative agreement with the CDC to provide education and awareness for healthcare providers and others on the topic of Chagas disease. So welcome, everybody. This is our agenda for the day, and I'm going to go ahead and go to the next slide, introduce our speakers. And as Cato said, we're going to have this be an interactive session. So if you do have questions, I'm going to help facilitate in the chat, and I'm happy to stop the speakers and ask questions, or you can also raise your hand. We're going to have time at the end also for lots of questions, and I'm just excited to have this topic. So I'm happy to introduce Major Joseph Marcus, who is at BAMC, Brooke Army Medical Center, as an infectious disease physician, also works as a professor with the Uniformed Services University of Health Sciences. His research interests include infections in the critically ill, as well as transfusion-transmitted infections. And I'm also excited that he has become a local expert. I'm going to call you an expert, Dr. Marcus, on Chagas disease. We're really excited to have you with us today talking about this, especially as it is very relevant for our military partners. As we know, people are exposed in the field to this and get deployed. And we have, as you're based in San Antonio, Texas, we have lots of triatamines there, and the possibility for transmission does exist locally as well. Next slide. Also very excited to introduce a wonderful partner, and I think I can call you my friend, Rachel. Dr. Rachel Marcus is a cardiologist. She's board certified and is at MedStar Heart and Vascular Institute. Also, this is still the correct bio, right, Rachel? I know you switched. Close enough. You can. You've had a couple of new roles, and as director of the Echo Labs at MedStar Unit and MedStar Good Samaritan Hospitals. Also, she's the medical director of the amazing nonprofit, the Latin American Society of Chagas. We call it La Socha. And she's an internationally recognized expert in Chagas disease, has consultation, sees patients all the time. She works with doctors who have questions about the disease, and has just been a wonderful resource in our Chagas community. Very passionate about the topic, has put out some great videos, and I show them all the time to people. So thank you, Rachel, for taking the time to be here. I know you're very busy. Both of you are very busy. We're grateful to have you both here and to share your expertise with us. I think with that, we should be ready for you all to get started. This is just at the end, we'll remind you to fill out the evaluation as well. I will let you all take it over. Thank you.
Okay, so I think we're going to start with me. I'm going to share my screen. I hope that you all see it. And play from start here. Okay, so everybody sees this? I've shared well. Okay, so the only reason that my CV matters is just to make the point that I am a cardiologist. I think unlike most everybody else on the call at this point. So you know, I do have that perspective when I think about Chagas disease. And also really the most important part of my CV is that I am the medical director of the Latin American Society of Chagas Disease, as Paula mentions. I work with the Latin American immigrant community in the Washington, D.C. metropolitan area that is extremely high risk for Chagas disease. And so most of the patients that I care for, or I would say basically 100% of them, are individuals who were born in a Chagas endemic country and bring the disease with them when they immigrate to the United States. And that has an impact on how I think about Chagas disease. So moving ahead, I have nothing to disclose. I like, though, however, that nothing to disclose shortens to NTD, because it reminds me to mention to my audiences when they don't know this already, and I imagine that most of you do, that Chagas disease is a neglected tropical disease, which means that we have to really advocate very strongly for people to think about it because people neglect it at every turn, including in the United States. Okay, so what is it? I know that a lot of you already know the answers to this question, but I'm just going to very briefly make sure we're all starting from the same base of knowledge. It is a parasitic zoonosis that infects smooth muscle cells. You can see on the right side of the screen the cluster of amastigotes in cardiac smooth muscle. It also likes the smooth muscle of the gastrointestinal tract. And also likes autonomic nerve system termini, so it infects nervous system terminals as well, particularly the autonomic nervous system. Okay, so who is likely to get this? Well, this is a disease that is associated with substandard housing, rural housing, poor of the poor in Latin America. Now, I realize that I'm speaking to an audience that also is likely to be seeing this disease, or maybe not necessarily likely, but might actually see this disease transmitted in the United States, as we know that happens. And Paula can tell you that the houses that she sees, the people where she's worried about Chagas disease, for them don't look at all like this. But my patients' houses look like this when they grew up poor in rural Latin America. They have poorly plastered walls. You can see if you pull a piece of plaster off, you see these bugs that are hiding there. And they're pooping all over the place, and that becomes important a little bit later. But this is really for the majority of people in the world who have Chagas disease, likely to be the way that they got it, from living in close proximity with these insects. And this is what the insect looks like. There are a variety of different species, subspecies, and they have a variety of different names, but suffice to say in the United States, we refer to it as the kissing bug. And then these other names are dependent on what country the individual comes from. And you can see in orange the areas of the world that these bugs live. Bugs with parasite have been found from the sort of midway through Argentina all the way to the lower half of the United States. And I see somebody on the call from Delaware, which is a state that just recently reported its first triatamine insect with parasite. So this is what it does. This is a triatamine insect having dinner. You can see it's very thin proboscis here that is penetrating the skin. My patients tell me that this doesn't hurt, although my understanding is that in the desert Southwest that some of these bugs actually hurt quite a bit, and people can have anaphylactic reactions to the bite. But this patient probably is asleep. It often is biting on the face or the exposed skin, and it has a long blood meal. And in Latin America in particular, while this bug is feeding, it has a gastrocolic reflex and it evacuates. And this drop down in the lower left-hand corner of the screen is fecal material that has parasite in it. And then what the unsuspecting victim does is it scratches the bite, maybe dragging some of this fecal matter back into the bite wound, or rubs the eye with the fecal matter, and that's the way that the parasite gets into the bloodstream and then is able to disseminate to the rest of the body. The first part of this disease then that happens after impregnation usually happens several weeks afterwards. And some of this timing for acute phase disease depends on exactly how it was that the infection was transmitted. We'll talk about that in a minute. But usually several weeks after the bite, people will develop nonspecific symptoms. And my patients never are able to tell me that they remember the time they had Chagas disease, in part because they live in homes with thousands of these bugs and they're probably bitten repetitively. So they may not remember the one time they had an illness. Often they also are so poor that they wouldn't really have gotten medical care for it anyway. So very few of these folks actually remember a time that they had their case of Chagas disease. These symptoms can last for 6 to 8 weeks, sometimes fever of unknown origin, and about 5% of them can have a clinically important presentation with myocarditis and meningoencephalitis, in which less than 5% can be fatal. The interesting thing about this particular sign is that parasitemia is present, and treatment with antiparasitic medications are effective for cure in 70 to 90% of them. So it's really a shame that we aren't able to better identify people who have this acute phase disease, because we really can cure them if we find them. There's a picture here on the other side of the screen here of a young woman who has something called a Romanes sign. This is a painless edematous reaction in the palpebral fissures. She's likely been infected by fecal material into her eye. It can last for a month and is thought to be pathognomonic of Chagas disease. Most of my patients don't remember having had that. It's really pretty uncommon. And I think it can actually also happen to just getting fecal material in your eye anyway. But in any event, this is something that you might remember from your textbooks about reading about Chagas disease. So the sad news, unfortunately, is that some folks will leave this acute phase already with cardiac damage. And we know that by looking at studies of cohort studies that included children, and also some of the cases in acute phase disease that have been caught. And that particularly tends to happen with oral transmission. So up to 10% of these kids can leave with signs that they already have had damage to their heart on the basis of this parasitic infection. There are some other acute presentations that I like to remind people that they might see. The most important one, I think, is congenital Chagas disease, because, again, this is a time where we really can cure patients if they're identified. And congenital Chagas disease, unfortunately, generally is also not symptomatic, so we can't really know for sure that the baby's infected. And probably 10 to 40% then will present with something like a Torch syndrome, premature hepatosplenomegaly, anemia, and high drops. But in general, because these babies often are asymptomatic, the way that we might know about it is by screening mom and knowing if mom has disease, and then screening baby on the basis of that. There's reactivation disease also, which can be important, particularly for infectious disease physicians that work with transplanted patients. So there's disease and with HIV. So there's disease-induced immunosuppression, including HIV, generally AIDS with CD4 counts less than 200, but also from malignancies. And this can have a neurologic presentation. With HIV and AIDS, it actually looks an awful lot like toxoplasmosis, and it does not respond well to anti-toxoplasmosis therapy. So you have to have a high index suspicion that your patient might have reactivation T. cruzi. Then there's also medication induced from transplant immunosuppression that tends to manifest on the skin or with cardiac disease. Fortunately, we look for that very aggressively in transplanted patients. So hopefully it's not too much of a surprise, but it can be. There's oral transmission also, which it is possible that you could see in the United States if you had a patient who returned from an area of the world where there are bugs that have gotten ground up into juice that has not been pasteurized. So there have been outbreaks throughout the north of South America, in particular with things with acai juice and sugarcane juice. And that actually is a fairly fulminant infection. And then finally, it can be transmitted via transfusion and donor organs. The good news is that right now we screen all first-time blood donors for Chagas disease. So hopefully we've reduced that risk, but not all networks actually screen their organs. So we can see a reactivation disease in a patient who received an infected organ. Anyway, moving along from acute presentations, we think that without treatment, every patient goes into the indeterminate phase of the disease, which is basically lifelong unless the patient then goes on to develop chronic disease. And because we've just acknowledged that most of the folks who've been acutely infected don't get treatment, this is going to be the vast majority of the patients that we see. So, and what this means is it's a patient who has positive serology for Trypanosoma cruzi infection. And the really important thing, and why I put the red star there, is it has to be 2 different tests. So we have to remember that we're working in the world of Chagas disease in the United States, that most people really are not up to speed on how it is that this should be diagnosed, including, unfortunately, infectious disease physicians who work with this population. So you have to remember, you can't just send the same lab twice. You have to send 2 different tests. You can do that through two different commercial assays at this point. If you can send to 2 different commercial labs, I think Dr. Marks is going to talk about how you would do it through the military. But for me, and I think a lot of people at this point, the place we like to send our confirmatory testing after we've gotten a commercial lab positive is to the CDC. I put PCR up here because I will have infectious disease physicians sometimes tell me that they've sent PCR for confirmatory testing. That is not the correct test. PCR can be positive in chronic disease, but does not have the appropriate test accuracy in order to be able to make the diagnosis of chronic disease. Up to 50% of people who are chronically infected will have positive PCR, but that's nowhere near 100%. So the diagnosis for indeterminate phase disease is based on serologic assessment for antibody against the parasite. The great news about indeterminate phase disease is it's at the end of significant manifestations of illness for 70 to 80% of patients. We do think that about 2% per year of this group of indeterminate phase will progress to develop cardiac disease. So they certainly warrant surveillance, meaning you don't get to the point of declaring that somebody has indeterminate phase disease and say, Godspeed, you don't need any more medical evaluation. These patients need to be followed because they do have a risk of developing cardiac disease over time. And what does that cardiac disease look like? Well, it's the chronic phase of the disease. And in minimum, we define this as positive serology and an abnormal EKG. I put a star there because this is the time-honored way of thinking about cardiac Chagas disease. And I'm really going to be speaking mostly about cardiac Chagas disease, although we have to acknowledge it can also cause gastrointestinal pathology. And we can talk about that briefly, but I tend to focus more on the cardiac disease because it tends to be more important clinically and much more common. So why do I put an asterisk by abnormal EKG? Well, because there are patients who have normal EKGs who have abnormal, more advanced imaging, including echocardiography and MRI. And we don't really know exactly what that means, but our supposition is that somebody who has an abnormality on echo that's consistent with Chagas or an abnormal scar on an MRI is probably somebody that we ought to think about differently than somebody who has a normal EKG and normal additional imaging studies. This generally presents about 15 to 30 years after time of likely infection, and most of the people who are getting infected repetitively are children. So this is often in a young adult or a middle-aged adult. And again, 20 to 30% of patients will progress. It's not really clear who, although we do have a sense that more men have significant cardiac disease. Could this have to do with degree of parasitemia, with reinfection rates, with manual labor? I put that in red here because I realize in talking to a military audience that you have a lot of recruits who are undergoing very vigorous physical exercise, and this could be particularly important to them. In general, a cardiologist does not want somebody to be getting vigorous exercise if they have myocarditis. We'll talk about that in a minute. Whether or not there's important issues with strain type and genetic factors in the immune response. So gastrointestinal manifestations occur in about 10%, and we think it's more common in South American trypanosomiasis, given where most of the individuals who moved to this country from Latin America come from. That's going to be a pretty significant minority of the patients that we're going to see that are at risk. Okay, so what is the cardiac pathophysiology? So basically the bottom line, if you look at the graphic on the right, is everything coalesces around myocardial damage and fibrosis. So this is a myocarditis. There are 4 different main mechanisms that we think might get us to this final common, sort of the final common pathway. The first is that there's parasite persistence. We can find evidence of the parasite in the tissue using PCR. in areas of lymphocytic infiltrate. So it's a lymphocytic myocarditis. We also see immune and inflammation mediated injury and dysregulation. So we can see autoimmune responses. We can see just the damage from the immune system towards the cells, including TGF beta, TNF alpha, things like that. Microvascular abnormalities, which include intimal proliferation and arteritis, abnormal vasodilatation, and consequently watershed ischemia, and autonomic derangements. It causes a dysautonomia that's on the basis of disruption of the autonomic nervous system. So again, all of these things then coalesce around the myocardial damage and fibrosis. And so what does this look like? Well, these 4 slides, I think, are going to show you really the spectrum of disease, and I think they do them really elegantly. The first slide that I have here is a slide of the left ventricle of a patient who had an autopsy for presumably from dying from Chagas disease, Chagas cardiomyopathy. What you see is a dilated left ventricle. You see towards the apex here that there's some white fibers here. That's actually scarring at the apex. What you also see is an arrow pointing to something we don't want to miss, which is an apical thrombus. So this is a patient who in all likelihood presented with heart failure, may or may not have presented with arrhythmia on the basis of this scar, and may or may not also have had embolic phenomenon related to the LV thrombus. So, but in all likelihood presented symptomatic and then was found to have this disease. So this is a patient where we might make the diagnosis of Chagas disease because of their presenting symptoms and then hopefully have some time to intervene. That is in distinction to this patient here who has much more normal myocardium. This is the left ventricle again on both sides. It looks a little bit hypertrophied, which really is not a Chagas thing. Maybe they had hypertension as well. So, and then they have a focal apical area of white. This here is scarring, very intense scarring at the apex. It causes a focal aneurysm that's fairly typical for Chagas disease. This is a patient who could have had a thrombotic event or a thromboembolic event, a stroke, as their first manifestation of disease, meaning they could have been entirely well and then all of a sudden had a massive right middle cerebral artery stroke. The only way we're going to know that this patient is at risk for this phenomenon is really by having done screening, not diagnostic testing per se, but screening, because this patient might be asymptomatic until the point in time when they have this massive life-altering event. The same thing might be said for this patient here. This is a patient who has normal myocardium in their inferolateral wall in the mid portion and down towards the apex. But in the base here, you can see it's much thinner than it is a little bit downstream. Why is that? Because of the focal scarring that occurs because of Chagas disease. It's a scarifying cardiomyopathy. And unfortunately, this area is associated with ventricular tachycardia and sudden cardiac death. So this is a patient who could have been doing just fine until all of a sudden he has VT and arrests. There could have been no preceding symptoms, no way of knowing that this patient was at risk for this disease. The only way we're going to know this is by doing screening to look for these patients so we can start to do the cardiac evaluations that might tell us if this is somebody who should be appropriately risk stratified for ventricular tachycardia. This final slide here is of the His-Purkinje system. It reminds me to remind you that Chagas disease is arrhythmogenic in more than one way. This is something that can cause bradyarrhythmia, so these patients can present with complete heart block or other degrees of heart block and syncope as a result. So we've just talked about most of these symptoms. Just to run through them again very briefly, patients can have angina from microvascular disease because of the watershed ischemia, exertional intolerance because of chronotropic incompetence, or also just because they have heart failure, palpitations and syncope because of autonomic issues, bradyarrhythmias and tachyarrhythmias. The red star is for me to remind you again that these folks don't necessarily have to have bad hearts. They can have very focal abnormalities, so ejection fractions that we wouldn't really worry very much about in the cardiology clinic, and still die or have horrible catastrophes from Chagas disease. Heart failure and then stroke. Again, the same thing here with that apical aneurysm sometimes being the only cardiac lesion. And there are higher rates of atrial fibrillation in individuals with Chagas disease, probably because they have an atriopathy as well as a ventriculopathy. Okay, so my patient confirmed positive for Chagas disease. What do I do now? This is the time I wanted to really briefly run through who it is we should be looking for with Chagas disease to begin with. So how do you even find a patient to confirm? So there are recommendations, not guidelines, unfortunately, yet, but recommendations right now from a group of folks, including several people who are in this group today, about about who we might want to screen. And what you can see here is that anybody who was born or lived for a prolonged period in areas of Central America, Mexico, South America with endemic Chagas disease should be screened. First-degree relatives of those people, people who have entomologically confirmed or highly suspected exposure, bites and or triatomine kissing bugs found in the home in states with known presence of triatomine species. So that's really important for people living in the desert Southwest in particular. Travelers with confirmed exposure to triatamines, and women of childbearing age who've lived in a region of Mexico, South or Central America. Most of these are strong. A couple of them are conditional. We can talk more about that later. Okay, so just to answer the question then of what are we going to do? So the first thing we're going to do, the patient is confirmed positive for Chagas disease. We're going to get an EKG to see whether or not, in addition to having Chagas disease, they have Chagas cardiomyopathy. It's the main diagnostic criteria. What are we looking for? This is a meta-analysis of about 32,000 patients, a third of whom had Chagas disease. And these are some of the main things that are sort of jumped out of the data to say are really associated with Chagas. Left anterior fascicular block, PVCs, first degree AV block, afibrar flutter, bifascicular block, or right bundle branch block. One of the things that I want to say is if your patient comes in and you've done your EKG and they don't have something that's on this page, but their EKG is abnormal, you still have to worry about them. There's several things that could show up on the EKG that still might be associated with Chagas cardiomyopathy. These are just the textbook ones. But if a patient has low voltage or left bundle branch block or other things, we still have to say their EKG is not normal, and we have to worry about whether or not there's been cardiac damage. Rhythm monitoring then is going to be the next step for anyone who has an abnormal EKG. And if the patients have a normal EKG and they're symptomatic, I would do it too. But if they have a normal EKG, echo, and they're asymptomatic, I think you're okay. You're looking for any sort of subclinical signs of brady or tachyarrhythmias, and particularly for tachyarrhythmias, because that's going to be something that's going to make you worry about your patient that might be at risk for lethal VT. Echo is something that's really important. We have some from this particular paper here is recommendations for multimodality imaging for patients with Chagas disease from the Journal of the American Society of Echo. We recommended in this paper that anybody who is newly diagnosed gets an EKG and an echo at the time of diagnosis. Why? In order to be able to catch the people who don't have abnormal EKGs but might have abnormal echocardiograms. Then across the different stages of disease, we have stages of Chagas cardiomyopathy. We have an indeterminate form A, positive serology with normal EKG, B1 and B2 disease, which are without symptoms, but either having structural cardiomyopathy and no heart failure or having LV dysfunction and no heart failure. C and D, C is LV dysfunction and D is really, really bad. And heart failure, D is bad heart failure. What we're looking for are signs of a deteriorating heart, including wall motion abnormalities that typically occur in the inferior wall, infralateral wall, apical aneurysm. And then we can look for some subclinical markers of disease like diastology and strain. MRI can also be helpful, although it hasn't really worked its way much in terms of the flow charts that are really published, in part because most of these patients live in resource-poor environments and getting an MRI is pretty tricky. That being said, I love MRI for any of my patients because I think it really gives us the best way of looking to see whether or not patients have scar. And we know that 8 to 40% of patients with Chagas disease with normal EKGs can have scar on their MRIs. We know that the magnitude of scars associated with outcomes, and there's a role for risk stratification for AICD. So how do I treat my patient? My patient comes in, I've done this evaluation. So here's a treatment algorithm, positive serology. You do your initial evaluation. If that's normal, you're going to be considering antiparasitic treatment. We're going to come back to what we do if it's abnormal. So if it's normal, we want to consider antiparasitic treatment. What's the data? Well, this is a nice table that goes over where there's strong recommendations for treatment and conditional recommendations for treatment. It's really good data that was used to get FDA approval for both of the medications that are used to treat Chagas disease in children. So ages 2 to 12, the FDA has approved the use of both of the antiparasitic agents on the basis of randomized trial evidence. There is observational data that suggests significant decrease in risk of transplacental passage in women of childbearing age. It's pretty remarkable. It's observational, but it's really remarkable. There's randomized trial evidence that looks in indeterminate phase that really only looks at serologic and PCR endpoints, and none have assessed the impact on disease progression. So what that means is if we look over in this table here, for acute infection, we're definitely going to treat. For congenital infection, definitely. Children with chronic infection, definitely. Women of childbearing age, we're going to say strong, even if it's observational data, because we want to reduce the risk of maternal fetal transmission. Adults with chronic infection and no organ involvement, it's conditional. It's because we don't have the evidence to really make a strong statement about that. That being said, most of us who deal with this do actually offer treatment to individuals who are up to age somewhere around 50 or 60. PAHO doesn't have an age cutoff. A JAMA article that came out in 2007 or 8 did. And basically, it's because we kind of feel like if you get to that age and you haven't had a big problem from Chagas disease, you're unlikely to develop it. But that's sort of where it goes there. Now let's look at folks. So these are the two medications that we have currently approved by the FDA, benznidazole and nifurtimox. Suffice it to say, they are unpleasant medications to administer and more unpleasant to receive. They have a lot of side effects. Somewhere around 65 to 80% of patients will be able to tolerate benznidazole at the end of the day, and less for nifurtimox. That's all I'm going to say about them now. Okay, moving on to the cardiology population. So what do we do if the patient already has EKG abnormality or some structural heart disease? There is randomized trial evidence in this group. We have a paper that was published in the New England Journal in 2015 of 2,854 patients randomized to benznidazole versus placebo. Who were they? They were old. They had, old, I say, being older than this. In any event, they were older than some of the patients that you're going to see with Chagas cardiomyopathy. Mean age was 55. Great long-term follow-up. They were treated with benznidazole and then followed for 5 to 7 years. And what we see is that in spite of the fact that the PCR negativized very nicely with benznidazole, there was no difference in hard cardiac endpoints between the groups for almost any subgroup analyzed as well. The only thing that was seen was a reduction in cardiac hospitalizations, but everything else, there was no benefit between the two of them. So what do I do with this as a cardiologist? Well, it certainly makes me less enthusiastic, but at the same time, I am seeing people who are 2 standard deviations below the mean of age of 55. And so in a younger patient with less significant disease, I am actually likely to offer them therapy, particularly if they're female, and I might be able to reduce the risk of maternal fetal transmission. But overall, what I want you to know is that most of the patients in this trial were actually quite well. They had normal functional class, they had normal EFs. So it is not true that this was a trial of advanced cardiac disease. This is a trial of actually not particularly advanced cardiac disease in patients who were 55 years old. So you have to keep that in mind when you think about treating. So let's say we can't treat with antiparasitic therapy. What are we going to do? Well, in general, we're going to give guideline-directed medical therapy that was derived from studies of other kinds of patient populations, because there's not a lot of robust data in Chagas-specific patients. But that's where your cardiologist comes in. And with that, I'm going to stop. I'm happy to take any questions, but I'd like to turn it over to the other Dr. Marcus and allow him to speak to some things that are more specific to the population that you're going to be seeing. Thanks so much.
Hello, everybody. Thank you so much. Can you see my screen?
Yes.
Okay, good. Well, it's so nice to meet everybody, and it's really an honor speaking here with a lot of leaders in Chagas, and a lot of the data I'm going to be citing is from other people on the phone call. I know we have Army public health nurses, epidemiologists, medical students, occupational health doctors, infectious disease doctors. So it's really great that all of us are here to talk about Chagas disease in the military. I think it's something that comes up rarely, but when it comes up, a lot of confusion occurs. Just some disclosures. These are all my opinions, not the government's opinions. I'm going to be describing some medication use that's off-label, and then I'm going to be mentioning some products for testing and screening for Chagas disease that are that do not imply endorsement by the Department of Defense. We're going to be talking about screening for Chagas disease in the military. That I see several people on the phone call who are involved in those original studies. And then we're going to talk about some military unique challenges to diagnosing and treatment. So all of these studies that I'm going to be talking about come out of Joint Base San Antonio. For the non-military people on the phone call, this is a joint base, meaning that all the branches are here, including the Navy, the Space Force. There's no water near us, but we do have the Navy here. We're in San Antonio, Texas, and then we are the sole point of entry for the enlisted force. For the United States Air Force, the United States Space Force. So people come from around the world to Joint Base San Antonio to join the military. We also have a really large medical footprint. The largest hospital in the DoD is here, the Brooke Army Medical Center where I work at. It's also the sole point of training for all working dogs in the military. And next month, we'll learn more about Chagas disease in dogs. But 38,000 people from all over the world are coming here, and just doing the math, that's almost 1,000 a week coming here to Joint Base San Antonio to get their training. From the military point of view, we want to have healthy airmen, soldiers, sailors, etc. And the concern for something that causes sudden cardiac death and potentially is here in San Antonio is concerning. As we talked about last month, and that's a royal we, as our entomology colleagues across the street at Fort Sam talked about last week, tridamine bugs love the climate of San Antonio. And you can see this map from Texas A&M University showing the concentrations of different tridamine bugs. And in the heart of all of it is that star where we are in Fort Sam Houston, Joint Base San Antonio. So there's certainly concern for acquisition of Chagas disease while people are here in an environment where people are training a lot outside, kicking up the dirt, and lots of opportunities for these kissing bug bites. The interest in surveillance for T. cruzii goes back 20 years at least. And I saw Dr. Wozniak on this phone call and Dr. Cropper on this phone call, who were very involved in these initial studies where this table on the right shows various triatamine bugs that were collected at Lackland Air Force Base, is where all the basic trainees are, and also where all the military working dogs are trained. And up to 60% of the triatamine bugs were carrying T. cruzii, certainly concerning. And when they did a blood surveillance of military working dogs in 2007, 8% of the military working dogs were infected with Chagas disease, and these are dogs that spent their whole life in South Texas, meaning that they acquired it autochtonously, if we use that word with dogs, but they got it here in San Antonio or in South Texas. So we know that the vector is here, that there's bugs, and the bugs are somehow making it wade into a sentinel species. That's my bias as a human doctor, but the sentinel species being the dog. And so that's certainly concerning that there's going to be acquisition of Chagas disease or T. cruzii infection by humans through the mechanisms that Dr. Marcus talked about. Here's a case of that that I believe Dr. Stigler-Granados might have been involved in, but it was in 2016, a basics trainee who was born in the United States on blood donor screening tested positive for T. cruzii. They were asymptomatic, they were in basic training, they were a volunteer blood donor. They had an EKG with some abnormalities, including a first-degree AV block, and then a couple other blocks. They had a normal stress test, a normal echocardiogram. They were asymptomatic, but that cardiac MRI was positive, and the patient declined therapy. So this was someone who was only identified because he was a blood donor. So with that concern, there's been previous studies involving several people on this phone call looking at humans who are out in the field. And so, as I mentioned, there's a lot of different people training here, including people that spend a lot of time camping, a lot of time in rural environments, a lot of time around these dogs who we know are being bitten by bugs that are infected with T. cruzii. And so there was a large serosurveillance study that I cite here, where they looked at over 1,000 service members and with significant outdoor exposure. So these were mostly people who were in some sort of training environment where they spent a significant number of at least nights outside sleeping. And only 5 of those 1,000 reported having a bite. And all of them were negative by PCR, which we mentioned is not the best test, ELISAs and IFAs, which are 2 different diagnostic tests. And of these, one had a positive one positive test, but did not have confirmed disease. So 0 out of 1,000. So that is certainly reassuring when I mentioned that the vector is here, the vector bites humans, and that vector is infected with T. krusei. So does the U.S. military routinely screen for Chagas disease? No, we don't. But there's many people on this phone call from Army Public Health Nursing, from OC Health, that have probably been getting referrals for people who screen positive for Chagas disease. So who are we screening for T. krusei infection? And that's our blood bank. And this is something that I'm not sure everyone on the phone call is familiar with. I think we're the only blood bank that screens every single blood donation for T. krusei. So at most blood donor centers, it is just the first donation, but in the military policy at every blood donor center, we are screening every unit of blood every time. So that is just something to know when someone comes to you with a positive test. This is the first time donating blood. This would be the first time they've been screened. But if they have been giving blood time in the past, you would expect like they have been screened before if that was through the military. Blood donors are not everybody though. So if someone's having a cold, someone's taking has, I don't know, toenail fungus and is taking antifungal, someone has a cold, a UTI and is taking antibiotics, they're not going to be able to give blood that day. So it's not a universal screening. And then there's travel reasons why someone can't donate blood. So if someone just came back from a malaria endemic region, you can't donate blood for at least 3 months from one of those regions. And then if you resided in a malaria endemic region, it's 3 years after you resided in that region before you can before you give blood. And so certainly you can know that some of our high-risk populations for Chagas disease, especially for non-autochthonous transmission, so people who are not getting cases in Texas, might not be able to donate blood in the first place. So that's something just to keep in mind. On the next slide, I'm talking about the 2 main screening tests that we use in the military. There's other FDA-approved screening tests for Chagas disease that are screening blood donors and organ donors. These tests that we use here at JBSA are using the Abbott system, but certainly there's other systems, including Roche, that have similar sensitivities and specificities. So both the Abbott Prism and the Abbott Alinity S are the screening systems that we use here at Joint Base San Antonio. And in the FDA package insert, they are reported to be 100% sensitive. And that's something certainly if we're screening every single blood donation and someone donated before and we have a 100% sensitive test, we wouldn't expect there to be a missed case on their previous donation. We would assume that they were either seronegative and didn't have enough time for antibodies at their last blood donation, or that they acquired Chagas disease after their last blood donation. And then the specificities are both very, very high. So 99.86% or 99.98%. And just to do a little math, that's 14 out of 10,000 are going to be false positive, or 2 out of 10,000 are going to be false positive, which doesn't sound like much, but when you have tens of thousands of blood donors each year, it certainly will come up that you'll have false positives. In the package insert, there's several diseases that are listed as known false positives, and that's not surprisingly other kinetoplastids. So that's going to include things such as leishmania. It's going to include infections such as like other trypanosomes, like African sleeping sickness, Trypanosoma brucei, and then malaria are known false positives. A lot of those diseases are going to have the same screen because of the limitations of who can donate blood in our screening. Like who is being screened because of who's donating blood are also populations that have high endemicity of, for example, malaria, are not going to be our general population donating blood. So those 2 tests have the same recombinant antigens that you can see here. It's not too important to know what those are, but know that those are different than the FDA-approved diagnostic tests. And so when you're doing a diagnostic test for Chagas disease, you are testing for different antigens than you are if you're doing an antibody test through the Abbott or Roche system. For anyone who has a positive test, the FDA recommends a supplemental test. And here we do the ESA Chagas test. It's also made by Abbott. And it measures the same targets. So it's more specific because I mentioned there's a lot of There's not a lot, but there are false positives with the first test, and this is thought to be more specific doing the second test. But as I mentioned before, they're measuring for the same antigens. And this is from the FDA package insert, and you can see that in the 40,000 samples they tested, 58 tested positive in that PRISM test, and then of those 58, 9 were also positive by the supplemental test. So for a blood donor, if they screen positive and have a negative or indeterminate follow-up test on the supplemental test, their unit of blood is thrown out, regardless of what the supplemental test is. If they screen positive, no one is getting that blood. And they, regardless of the supplemental test, they're getting a letter from the blood bank saying that there is concern for Chagas disease. If their ESA was negative, they're going to say that there's a chance that they can donate again in the future in 6 months. But for those with an indeterminate test or with a positive supplemental test, they get a lifelong deferral from donating blood again. So what does the blood donor population look at Joint Base San Antonio? So we mentioned that we screened 1,000 people in that one study using 3 different means. We're actually screening in the years following, from 2014 to 2016, we screened 43,000 people. So we're screening a lot of people for Chagas disease in the military. Not all of these people are active duty. There's Guard, Reserve. There's also spouses, children who are over the age of 18 who are donating blood, who are affiliated with the military system. So not all of these are soldiers, but the vast majority of these are active duty. Of those 23 that screened positive, 8% had confirmed disease on 2 positive, so meaning they had 2 confirmatory tests that were positive. And then 1 had chronic disease or indeterminate disease, and they stayed in the military. And 1 was a patient that I mentioned earlier who had chronic Chagas cardiomyopathy. Going in the years that are following, from 2017 to 2022, we had 89,000 donors, and we had 5 positives for T. cruzi in that time. However, these are people that had a positive supplemental test, so positive Abbott screen, positive supplemental test. We actually had a lot more people, close to 50, who had a positive screening test with Abbott and then a indeterminate or negative supplemental test. So here's data that I'm going to talk about from JBSA from 2017 to 2022. We had close to 50 people who had a positive Abbott screening test and then a positive, indeterminate, or negative. I'm not sure if you can see my mouse, but it's in the middle of the table. Screen. So most people screen, despite testing for the same antigen, most people were negative on the supplemental, but 19 of those were people who had positive or indeterminate. Most people were in the Air Force, just because a lot were basic trainees. Most were enlisted. The median age was 21, and the majority were male. For these individuals who screened positive, 16 had documented in their chart that they were. Someone asked about risk factors for Chagas, and then 2 had risk factors present. In terms of workup, for people who had positive or indeterminate supplemental tests, and so these are people receiving a lifelong deferral, most of them had a follow-up appointment. Most of them had repeat testing. Most of them had an IgG sent to ARUP or the state health department. Many saw a specialist, with infectious disease being the most common specialist. The 19 people had 39 appointments with a primary care provider and 10 appointments with a specialist. The workup took about a month, and that for those in training, previously we were holding them in med hold, meaning they were doing no training. They were just waiting for the results to come back to see if they can stay in the military for about 2 weeks. And you can see for those who were negative, so they had a positive screen and then a negative supplemental test, that the workups were less frequent, and that there were shorter workups and less days in medical hold. For those with a positive screen and a positive ESA, so this means they had 2 tests that both showed these same proteins. We looked in the charts to see what sort of testing they had afterwards. Some of them had were asked for risk factors. Not all of them were. When using an ELISA that was usually through ARUP or the state health department, none of them tested positive. Looking at the Abbott PRISM results, some of them had later blood sent to an Abbott PRISM. So this is not a confirmatory test. This is an inappropriate lab that was ordered, but they put it through the machine months later, and they did not test positive on the Abbott PRISM for most of them except for 1. And then only one of these ended up being sent to Dr. Montgomery at the CDC and her team, and that one was negative. So despite having this 99.98 specificity on the passage insert, there's either something different about our population or there's something than was in the studied population. But even those who have two tests, we're seeing a lot of people who are not truly infected with T. cruzi by our current tests. This is just a quick slide I want to go over. For those in Army Public Health Nursing or in OC Health, there is a pathway to re-entry for people who screen positive and then have a negative ESA, that second test. However, and that involves using two different licensed screening tests, so like Abbott and Roche 6 months later, and the patient screening negative. We don't have access in our current blood bank system to do this. So anyone with a positive screen, and regardless of their supplemental test, essentially is getting a lifelong deferral from blood donation in the DoD. So we're running low on time. So what do we do at JBSA? And I know that it's going to be slightly different in every state, but there's an agreement between DoD and LabCorp for all our send-out testing. Most of our send-out testing, if you order it through the computer system, is going to go to ARUP. The second, the other way is certain states, such as Texas, offer in-house testing for Chagas disease. So it is by far the easiest for us and the quickest for us to go through our state health department. And if the screening through the state health department is positive, they will send to the CDC. Some challenges we have had has been people who screened positive donating blood in Georgia or Oklahoma, and then they moved to San Antonio. And so I would make sure, and then coming here with part of the workup done out of state. I would recommend finding a contact in your state health department for if there is testing done through your state health department, or if your state health department sends directly to CDC, to make sure that you coordinate how these patients are getting follow-up and that the samples are not getting lost. For those who have confirmed disease, we send for cardiac evaluation, which we do partially in the clinic with EKGs, and then Dr. Marcus, the other Dr. Marcus, Dr. Sigler Granados, have this paper from 2021 that talk about follow-up for patients with indeterminate form of Chagas disease. Benznidazole and nifurtimox are both on the DoD formulary. We mentioned how the toxicities are sometimes limiting. Their mechanism of action, the azole, for example, does not do anything with fungus. It is not a proton pump inhibitor. For our medical students on the chat, is a totally different mechanism, and it produces free radicals. Both of these are killed by free radical production, which obviously has off-target effects with human disease. But both are in the DoD formulary and can be ordered for home delivery through Express Scripts. I have not had, in the patients I've treated with Chagas, I have not had delivery getting these problems delivering these two medications. So some questions I'm bringing up for the group and something to think about is, how do we address these false positive screens? The number is much higher than like the 2 out of 10,000 that are screening positive in our sample. And that's leading to lifelong deferrals effectively in the military because we don't have a way to enter them back in. Are we screening the right people? There's certainly reasons people can't donate blood. And are those the same reasons that someone might have Chagas disease? And how do we figure out how to screen the right people? And then there's veterinarians on this phone call, there's public health officers or entomologists on this phone call, and then physicians. Like, how do we work together for this disease that infects not just humans, but animals? Like how do we do our work together to limit the effects of Chagas disease in the military? So just as some conclusion, the military has a lot of false positives. When you have a soldier sailor come to your office with a letter from the blood bank saying they have Chagas disease, if looking at the last 50 people that came to our office, none of them had Chagas disease. So it's not a reason to panic. It's a reason to be orderly and get the workup. Chagas is almost never an emergency. And so it's better to do the workup and before panicking. And put them in touch with a local infectious disease doctor or expert, such as Dr. Marcus or someone else who's on this phone call. The state health department is how we do it here in Texas, get our confirmatory testing, and then the therapeutics for Chagas disease are all on DoD formulary and do not require prior authorization. And that is the end of our presentation with some references that I'm going to leave up.
Thank you so much to both of you, Dr. Marcuses, This was fantastic. I want to kind of give everybody a moment to process. That was a lot of information. I learned a lot of new things, especially this last part of your presentation about how the DoD operates. So thank you for sharing this. This is really enlightening information. I kind of want to refer back to the questions that you posed on that second or third last slide regarding how do we do this better? How do we know exactly who we should be screening? Should we be screening everyone? One of my questions is, what are we doing with the people that are being deployed to Latin America? Are they being screened, after they return? And is that something that should be mandatory? I've been talking a lot with the global GICE. I always forget what GICE stands for, but they're the infectious surveillance system for DoD, and talking with them about how do we put policies in place that help the people that are being deployed to like Joint Task Force Bravo and Honduras, when they come back, should they be screened? Are they at a higher risk or not? And working with the entomologists, especially there at Fort Sam, who we talked with last month at our last ECHO session, and also like talking to some of the entomologists down at Joint Task Force Bravo, for example, and just learning that there's a lot of triadenines out there that have potential for people to be exposed to. So how do we have that integrated pest management piece in there? And the veterinarians being having the dogs as those sentinels that are there. So a lot of things that you brought up, I think, are incredibly important. But I go back to that: are we doing this the right way? And I'm wondering if anybody out there has questions or would like to contribute to that conversation. Feel free to unmute yourself or raise your hand. You don't have to, sometimes it gets a little quiet. We'll just wait a moment. You can also put it in the chat if you're hesitant to speak out loud. I'll be happy to facilitate your questions.
I'm just going to give my personal 2 cents on that question. I think it's a very much an open question right now of what is our risk, and it's probably not static for everyone deploying to Joint Task Force Bravo. I think we need to understand a little bit more of what the risk factors are, what people are doing in other countries, where they're staying in other countries. But I think it's certainly something that deserves further study to make sure we're not exposing our service members to any sort of vector-borne disease while they're abroad, just like malaria, dengue, and other things we know they're at risk for.
Thanks. I think a lot of times when I've been speaking with people about how do we do better with the diagnostics, we've talked about rapid testing. So there are these 15-minute rapid tests, but I think in the Chagas community, we're all in kind of an agreement right now that they're not there yet. We're not there. Those aren't also giving off a lot of false positives as well. So we're hoping that there's some, InBios has a rapid test that we're hoping they're going to have a second gen of that coming out soon that might be better. But I think also with the military population, especially those being deployed to these endemic regions, might be a really great opportunity to test this and see how this is going in terms of the viability of these rapid screening tests, because that's also something I think that we're looking in the future at how can we be better at testing. We're just not quite there yet with that. Julia, did you have something? I saw you pop up. I'm wondering if you...
Actually, yes. I keep thinking that one thing nobody says, and this is with respect to treatment of Chagas disease and recommendations for regarding treatment. When we say that there is no evidence that treatment with the present antiparasitics actually is successful, that is because we have no proof of cure, really, because outside of particular research settings, we don't have sensitive PCR, and like other infections, serology does not revert to negative after successful treatment. Just think, for example, about syphilis and the treponemal tests. Those are never going to revert back to negative. Or think about Lyme disease. It's not going to revert back to negative after successful therapy. So I would argue that, and this is with respect to Rachel's point, that treating children is successful and treating adults we don't know. The reason we don't know is because we have no test of cure. And just from a simple biological perspective, I doubt that the parasite is more susceptible in children than in adults to these antiparasitic compounds. I think it's just as susceptible in adults.
So I think that's controversial. It is absolutely a perspective that a lot of people in the Chagas disease community, that to call us that, have. So, and I have no way to either to resoundingly rebut it. But there are also, I think, a fair number of people on the other side who say it's not so much that it's being a child versus being an adult that matters. It's the length of the infection that matters. And that you may have laid down such consequences in terms of that sort of slide that I showed with the 4 pillars of pathogenesis of this disease, that antiparasitic therapy is no longer able to eradicate the disease. Even if you were to cure the infection, you wouldn't necessarily keep the disease from evolving. There's no reason to say that, and I weigh a little bit more on that side. There's no reason for anybody in this audience to say I'm right or you're right or whatever, but I think that we have to be a little careful. Tests of cure, to me, still are fundamentally secondary endpoints or surrogate endpoints. What I care about as a cardiologist is whether or not my patient is going to die from VT, die from heart failure, have a stroke. So the problem that means is that for us to do a study where your test of cure actually is matched with the clinical endpoint, when we're starting with patients who have indeterminate phase disease, is that study is enormous and has to go on for a decade, if not more. Mm-hmm. So it's a huge, thorny proposition. Now, all that being said, I treat people. I would have, Dr. Marcus presented a case where the patient didn't want to take the medication. I would have been someone who would have said, a young patient with bivesicular walk on their EKG, I would have said, I really want you to take it. They're young. To me, it feels like the length of infection feels really important. And I acknowledge that, I'm on one side of the spectrum, and there are a lot of folks, particularly, I think, ID folks, who are probably more comfortable with it's your world. I'm an interloper, but I'm kind of adamant that I want to make sure my patient isn't going to end up developing cardiac disease at the end of the day. And I'm not sure what kind of biomarker there is going to be that's going to prove that to me, unless it also is coupled with a cardiac endpoint study. Mm-hmm. So that's just my 2 cents about it. And it honestly, I don't know if I'm right, but that's where I live.
Yes, and I think there are, excuse me for replying and taking up time, but I think there are 2 separate issues, which is, are we eradicating the parasite, where I think adults' parasites will be just as susceptible as those of children, versus are we stopping disease progression that, as you say, Rachel, could be due to inflammatory responses that have become decoupled, potentially, we don't know, but potentially from the presence of the parasite, and maybe there is some autoimmune component that has been set off by past presence of the parasite. So I think those are 2 separate issues. And as an infectious disease specialist who thinks about, can we kill a parasite, I would say most likely yes. And not at all to minimize the importance of continued monitoring of the patient and of addressing their heart disease, regardless whether or not their parasite is still present.
Thank you both so much. This is a good commentary. Out of respect for time, I know we're like a few minutes over. I just want to say thank you, Julia, and thank you, Rachel, for thinking about this. And I do think this is a question that comes up often. I just want to mention too, really quickly before we go, and also thanking the presenters, but Sean in the chat had said, do you think there's an opportunity for screening higher risk populations in basic trainings by a questionnaire similar to one done for TB infection? And that's something we've been working on through our Global Health Engagement Research Initiative grant, is putting out policy propositions of what we think would be good, and having this screener is one we do think is appropriate. So have you lived more than 6 months or more in an endemic region? Did your mom come from an endemic region? Or have you lived in a place where you've seen active triatamines activity? We would suggest screening, especially women who are of childbearing age. That's kind of the bottom line for that. And the screener can just be a questionnaire. It doesn't have to be an actual test, and that would be where we start. And if they say yes to any of those, go ahead and screen them. And we hope that the military will accept that and put that into practice. And there's a good chance that we're working towards that right now. So with that, I really want to thank our speakers. Thank you both so much for your time and your energy. And I know you spent a lot of time prepping for this. And thank you all for who attended. We're really grateful for your time. Thanks for sticking around for a few minutes. I know since we're military, we want to be really on time. So I know I'm running late. But thank you all so much for being here. We do record these sessions, and you can go to our UT Health link. It's in the chat. Here's a QR code if you want to scan it. If you do want CME for these, we'd love to give it to you. So please fill out the evaluation. And if you have questions, feel free to follow up with any of us. You can reach me through the websites, or I will put my current email in the chat. And we will follow up with you via email for the CMEs, et cetera, and thanking you all for coming. So thank you. September, we're going to have another session for the veterinarians, so stay tuned. If you came to this session, I hope you don't mind. We're going to send you an email about the next session, and if you can make it, that would be great. And we are also talking about, last thing, probably in October, we're going to have a session that's going to be focusing on the health departments. So I think that would be a really great opportunity to talk about case definitions and how health departments play a critical role, as Dr. Marcus mentioned as well. So thank you all so much for coming, and I hope to see you next month as well.